The reason for creating a video on this topic is because it's one of those topics you end up learning by doing, aka, as a medical student, I would pick up a few terms here and there related to diet, and on rounds, try to pick a word that might fit, hoping it didn't sound ridiculous. So the best way, I think, to think about diets is on a continuum. On one end of the spectrum, you have NPO, and on the other end of the spectrum, you have regular diet. And typically, you're going to be trying to advance a patient, in the most extreme cases, from NPO to a regular diet. Let's talk first about our end goal, the regular diet. This is basically a standard diet with no restrictions. It's the most advanced diet you can give a patient and is suitable for anyone who can eat solids and who doesn't otherwise have other comorbidities or diseases which would merit restrictions. We'll talk about these a little bit later. So I'll assume that you know that NPO means nothing by mouth. So the next step up from NPO is a clear liquid diet. This means clear juices, thin broths, or jello. The next step up is a full liquid diet. This means anything that can turn to liquid when at room temperature. Includes citrus juice, milk, ice cream, or cream soups. It's typically used as a transition between clears and the solid diet, and can provide 1,350 to 1,500 calories and 45 grams of protein per day. Now, on the surgical floors or the OB floors, basically in any post-op patient, you're typically picking between one of these four diets. For example, in someone coming out of an abdominal surgery, which is the most extreme case since you typically have an ileus after abdominal surgery, a patient is typically kept NPO until they start to have bowel function. By bowel function, I mean bowel sounds or passing of gas or flatus. Once there's evidence of bowel function, the patient is typically advanced to a clear liquid diet. If the patient can tolerate this clear liquid diet, which means no nausea or vomiting, they can then be advanced to either a full liquid diet or to a regular diet. This is typically attending dependent, and some attendings may wait to advance someone to a regular diet once they start passing stools. Now, there are a bunch of special diets that you might see in the hospital. These include pureed, or thickened liquids. And these are typically for patients who have had head, neck, esophageal surgery, or those with dysphagia who can't tolerate solid food boluses, or other patients who are at risk for aspirating liquids. Another type you might see is called the post-gastrectomy diet, which means multiple small meals substituted for 3 large meals, since after a gastrectomy, you can't tolerate meals quite as large. With this diet, they also limit the carbohydrates to prevent dumping syndrome. And beverages and liquids are also limited to prevent early satiety. Another diet you might encounter is called the soft diet, wherein fiber, texture, and season modifications are made for patients who cannot tolerate a regular diet. You might also hear of the bland diet, which is used for patients complaining of heartburn, nausea, vomiting, or bloating. And it's made of foods that are soft, non-spicy, and low in fiber. Now, on the medicine floors, you might see patients on diets related to an underlying disease process. For example, the fiber-restricted diet. These are low-residue diets, which are given to reduce feces or prevent blockage as strictures. And as you might guess, it's commonly used for intestinal inflammatory states or IBD patients. On the contrary, you might have high-fiber diets, which are sometimes recommended for patients to prevent constipation or diverticulitis, though some controversy exists over the effectiveness of this. There's the low-fat diet for patients with fat malabsorption or at high risk or who have atherosclerotic disease, as well as the diabetic diet or carb-controlled diet, which basically means a strict monitoring of fats, carbohydrates, and proteins. Another diet you might see is called the sodium-restricted diet. These are typically for patients with renal disease or bad CHF and may also be used for hypertensive patients. The amount of sodium can be restricted to an amount selected by yourself, but is typically limited to 2 grams of sodium. Now consider this. A typical American diet contains about 10 to 12 grams of sodium, so just imagine how your patients might feel when you prescribe a diet that's 1/10 as tasty. I once had a 5-year-old who had nephrotic syndrome and refused to eat any food because it had no taste in comparison to her mom's typically salty food. Finally, you might see the renal diet, and this diet is just modified with amounts of protein, phosphorus, potassium, and sodium, and fluid content, depending on the type of dialysis a patient might be undergoing. And now for the take-home points. First, you should think of diets as a stepwise progression from NPO to regular diet. Patients are advanced depending on bowel function and ability to tolerate their current diet. And on the medicine floors especially, remember to consider special diets such as low-fat, carb-controlled, sodium-restricted, and high and low-fiber diets. Thank you.